Thanks so much for having me. Can you hear me okay? Excellent, perfect. So I'm super excited to be here. This is one of my favorite things to talk about. And I've titled this talk, None Born Positive. And I've replaced prevention, which we used to say, with the word elimination. And I hope over the course of the next hour to convince you all that not only is this goal possible, particularly in the United States, but it's really the only goal that we can have. And so we'll walk through the steps on how we can achieve this collectively. So we're going to do this in 4 steps. First, we'll talk a little bit about HIV epidemiology in the United States. We'll then transition a little bit into HIV biology. And for those of you that don't like biology, I promise it'll be quick and painless. And then we'll spend the bulk of the talk talking about best practices in elimination of maternal to child transmission. And then we'll touch on some of the psychosocial, legal, and ethical issues that come to play when caring for this patient population. So we'll start a little bit with HIV epidemiology. And I'd say 20, 25 years ago, you really couldn't open a magazine or newspaper without seeing something about the AIDS pandemic, the HIV virus. What was its origin? Magic Johnson contracted HIV. The AIDS quilt was moving around. And if you look at the magazines or New York Times over the past couple weeks, barring Charlie Sheen and that incident, you really won't see a whole lot about HIV. And the reason for that isn't that HIV doesn't exist anymore. It's far from that. It does mean that things are a lot better, but there's still opportunities for improvement. So this graph depicts HIV-related deaths. Let's see if this, no pointer, well, bear with me. On the y-axis is HIV-related deaths. On the x-axis is year. Now the AIDS was discovered in 1981. And the HIV virus was discovered in 1983. And what you can see is that HIV-related deaths increased year by year in a really alarming trend in this blue line up until the mid to late 90s. At that point, we had developed enough antiretroviral medications and learned that, hey, if we use them in combination, we can control the virus and control the suppression of the immune system. And so once we reached a kind of a critical mass of medications, we were able to curtail this rise in HIV-related mortality. And you can see this sharp decline in the red box. Just over a couple years, we dramatically decreased HIV-related mortality, which is amazing. What this means, though, is there's a huge improvement in health, but it also means people with HIV, of course, then are living longer and healthier lives. It's a wonderful thing. And what that means to me as an obstetrician is that women want to get pregnant and are able to get pregnant. And again, that's an awesome thing. So a lot more women with HIV were becoming pregnant. This is from the CDC, and they estimate right now about 1 out of every 4 individuals in the United States living with HIV is a woman. And what they estimate is that approximately 15,000 women each year in the United States are diagnosed with HIV. 80% of these women are of childbearing age, and so approximately 5,000 to 6,000 women each year are giving birth that are HIV positive. This graph depicts current HIV acquisition and the racial and ethnic disparities that exist. And there continue to be some pretty profound racial and ethnic disparities. So you can see Black women are markedly more likely to contract the HIV virus, followed by Latina women, and then white women. But what this graph tells us is there's no community that's risk-free. There's no region of the country, there's no racial or ethnic group that doesn't have any HIV virus. All women are at risk. Now, how do women in the United States contract HIV? So this, again, is from the CDC. Most recent estimates, the overwhelming majority of women contract HIV through heterosexual sex. So 85% of acquisition is in this manner. IV drug use is absolutely a risk factor, but much less common epidemiologically, and then a handful of other causes. What this tells me is that all sexually active women are at risk of contracting HIV, and it's our job to inform this counseling. Now, what's interesting is that due to some of the biologic changes of pregnancy, pregnant women are actually at a higher risk of contracting HIV compared to non-pregnant women. And so our job is to encourage all pregnant women to practice safer sex. The what does that mean? What does practicing safer sex mean in the context of a pregnant woman? I think there's some things that we think about often, right? So monogamy, making sure a patient is potentially monogamous with her partner. Or if she has a new partner or multiple partners, recommending the use of condoms, particularly during a pregnancy where we know she's so at risk. But I think something we don't think about often, but I think is a huge component of safer sex, is knowing her partner's HIV status. Can we really say that a patient is having safe sex if we don't know the STI status of who she's with? And so Dr. Garcia and I set off on a needs assessment here at Northwestern to look at what do patients know about their partner's status. And so we asked 142 women in our PAC clinics, or a hospital-affiliated low-income clinic, do you know that your partner's been tested? Do you know his results? And what we found is that only 60% of women were aware that their partner had ever been tested. Only half of those women knew the result of that test. And then only 20% knew that their partner had been tested within the past 6 months, so kind of within the confines of when this patient was pregnant. So you can tell there's a lot of need here in terms of patient education about informing them of partner status. So this, in my opinion, is one of the more sobering graphs on the epidemiology of HIV in the United States. And what you can see here is that overall there's approximately 1.1 million Americans living with HIV. Only 82% of that 1.1 million have been diagnosed. So 20% of individuals don't even know that they have the HIV virus. That's pretty scary. It drops even further when we think about linkage to care. Only 66% of HIV positive individuals are linked to medical care. It drops even further with retention. Only 37% of individuals are retained in care. 33% are prescribed antiretrovirals. And this leaves us with only 25% of HIV positive individuals in the United States being virally suppressed, which is ultimately our goal. So this is very sobering, it's very alarming, but I think it also should be really empowering, because each of us in this room has a skill to get each of these bars up, to improve screening, to improve linkage to care, to engage our patients in retention and care. And so I see each of these as an opportunity for us to have a better graph in a handful of years. Okay, so we're going to transition to HIV biology. Again, sincere apologies to those people who do this full time. This is going to be a very crude description, but I promise painless. So the HIV virus, it's mean, it's ugly looking. It's a member of the retrovirus family. It's a single-stranded enveloped RNA virus, right? And it's, look how ugly it is. It's got like a ninja star, it's real aggressive. It has to enter the body directly, and it can enter the body either through blood, through genital secretions, or through breast milk. And that middle picture is the best I could do to depict genital secretions. So the Google search was a little alarming. So once HIV gets into the body, there can be an acute mono-like syndrome, so very nonspecific fevers, aches, chills, there's some malaise that occurs. It could also be completely asymptomatic. And so you can see from that prior graph how easy it is for people to not get diagnosed, because oftentimes they don't notice that something different has happened. Once it enters the body, that mean HIV virus wants to use the machinery of our own immune system to replicate. And in doing that, it kills some of the cells of our own immune system. So this is our depiction of the chief army cell, the CD4, the helper T cell, surrounded by macrophages and dendritic cells, so kind of the front line, so to speak. And what that HIV virus is going to do is infect these cells, kill them off, and ultimately seek to kill all the army chiefs that it can. So ultimately, our army chief is going to fall, and when those T cell numbers decline below a critical level, our cell-mediated immunity is lost, and the body becomes progressively more susceptible to opportunistic infections. So this point in the disease is what we would call AIDS. So AIDS is either when CD4 cell number falls below 200 cells per microliter, or there's a development of one of these opportunistic infections, infections that are incredibly unlikely when there's a normal immune system present. So how does that HIV virus get into that chief army captain and destroy that cell? Well, it has a series of steps that it has to go through to do this. So this depicts a CD4 cell and the HIV virus on the top that's trying to enter. That virus first has to enter by fusing to the cell membranes. Then it enters, and that RNA virus, remember it's a single-stranded RNA virus, that RNA virus has to be reverse transcribed into double-stranded DNA. That double-stranded DNA then has to be integrated in the nucleus of the CD4 cell into our own DNA. And once it's integrated, it then will be transcribed into proteins. And those proteins are packaged together into other HIV particles that are then released into the body. Now, the good news is we have drugs that target each of these steps. So we have entry inhibitors or fusion inhibitors that block entry of the virus into the cell. We have NRTIs or NNRTIs that block that reverse transcription, so prevent the RNA from becoming DNA. We have integrase inhibitors that keep that DNA from integrating with our own DNA. And then protease inhibitors that keep those proteins from packaging together and developing. When used in combination, these are powerful medications that can prevent replication of the virus, so suppress the viral load, and protect the immune cells from being taken over and destroyed. And that wasn't too bad, right? Cartoons are good. Okay, so we're going to spend the bulk of the time here talking about elimination of maternal to child transmission. And I want to go through best practices, so walk through each aspect of pregnancy and how we can apply the science that we know to eliminate cases of maternal to child transmission. So before we begin, just a brief overview, what's gone on historically. So EMTCT has been hailed as one of the most successful public health prevention initiatives in the HIV epidemic history. And the reason for that is depicted here. So the purple line depicts rates of transmission over years. And what you can see is in the early 90s, rates of transmission were 20 to 25%. And that's because we truly had no intervention other than avoidance of breastfeeding to prevent maternal to child transmission. You'll see this first declination point number 2, that happened in the mid-90s. And that represented, remember, the advent of some of these antiretroviral medications. So we learned that we could disrupt the replication of the virus in the woman and thereby prevent transmission to her baby. And so we saw a dramatic decline when we started to learn about these medications. Then in the late 90s, there was a trial, and we'll go over the trial in a little bit more detail. But we learned that there's some things we can do during labor and things we can do after delivery to further prevent transmission. And so we reduced it even further by about 2/3 with that publication of this trial. Since that time, we've had slow and steady decreases. And over the past 5 to 10 years, rates of perinatal transmission in the United States and other industrialized countries have stayed steady roughly at about 2%. Now, I don't want to diminish how successful this is. Going from 25% to 2% is really profound. But I'd argue that 2% is not good enough. And I say this for 2 reasons. One of them is, I hope to convince you over the next few slides, we know the science behind HIV biology. We know what stops it. And here in the United States, we have the resources to link patients to the right care, to make sure that they're taking medications, making sure we're in the right hospitals that have the resources to prevent transmission. So unequivocally, we can do this. The other big issue is there's some really profound disparities. So if we look in the United States, about 35% of infants born are African American or Latino, right? 35%. But when we look at cases of perinatal transmission, 85% of cases of perinatal transmission is in that population. And that disparity is really, I think we'd all say, completely unacceptable and tells us that there's a lot of work that we need to do and we can do. So when does infection happen and how likely is it? So let's take a hypothetical cohort of 100 women who are HIV positive. They breastfeed, we do nothing. We don't screen, we don't intervene, they just kind of deliver. 75 of those infants will not be HIV infected. So the body has a really amazing way to try to protect against transmission. But 25 infants are going to be HIV infected if we do nothing. Now, when do those infections happen? about a third, 30%, are going to happen in utero. So this happens during the pregnancy, before labor starts. And this is because the virus, either due to a disruption in barriers in the placenta, infection that makes that area weak, can get through from the maternal circulation through to the placenta and into the fetal circulation. There's specific risk factors for this. So infection with other sexually transmitted infections. If a woman seroconverts, so contracts the HIV virus during her pregnancy, in utero transmission is more likely to occur. And most of this in utero transmission happens in the later third trimester. So not in the beginning of part of pregnancy, but later on. The overwhelming amount of perinatal transmission happens intrapartum, so during the labor and delivery process. And the thought behind this is that labor disrupts that maternal-fetal interface, right? There's a lot of exchange between maternal and fetal blood that occurs during that entire process. In addition, a baby that's born is exposed to maternal blood and genital secretions, which can contain that HIV virus. And so about 50% of infections, if they are to occur, would happen in that intrapartum period. And then if we were to allow breastfeeding, approximately 20% of infants would be infected during breastfeeding. Again, that HIV virus is able to be secreted in breast milk, and so it can be transmitted in that manner. So what I want to do is take each of those steps, that antenatal, intrapartum, and postpartum, and really dissect the literature on how can we prevent this, so we can know what our best practices are and how we can intervene. So we'll start with antenatal care. So the mainstay of caring for these women is diagnosing HIV, right? We can't initiate any of these treatments if we don't diagnose. And so in September of 2006, the CDC revised their testing policy, and we're actually lucky enough to live in a state that the state legislature has not only allowed, but mandated adherence to this style of testing, where all pregnant women should receive routine, universal HIV screening with the right to decline. So what does that mean? That doesn't mean she comes in and we say, hey, we have this extra special test if you want to get it, sign these extra forms, because you can see that's a huge barrier. Women are reluctant. They say, oh gosh, I'm not at risk, or I don't want to go through any extra special testing. But rather, this is standard of care. This is an important test. I recommend that you have this test along with the rest of your prenatal labs. And so that's kind of routine testing here. Now, third trimester testing. So the state of Illinois, and particularly the city of Chicago, it is strongly recommended that we perform third trimester repeat testing. Because just because we know a woman's negative in that first trimester doesn't mean she may not be at risk throughout that pregnancy. And we know that if she seroconverts during the pregnancy, her risk of perinatal transmission is so much higher. And so because our prevalence in the state of Illinois is more than 1 in 1,000, it's recommended that all women undergo repeat testing in the third trimester. This would also apply in lower prevalence areas where if a woman had particular risk factors or had previously refused testing. So again, just to emphasize, determining the HIV status of a pregnant woman is really the gateway to all of these interventions that we're going to be talking about. So if this is state law, how could cases be missed? What's going on? How could women fall through these cracks? And so there was a mixed methods study that looked at providers and, as well as patients and asked them if their testing was missed, why was it missed? And these are the top 4 reasons why testing wasn't performed during a pregnancy. The first was language barriers, right? That it does take extra time to communicate the pre-test and post-test counseling in a different language. The second was late or no entry into prenatal care. The third was that either the patient perceived herself that she was not at risk, or the provider felt that she was not at risk. And then finally, and I think really importantly, they found that if a provider strongly recommended HIV testing, that patient was significantly more likely to adhere to HIV testing recommendations. So we absolutely have the ability to influence acceptance of testing by offering universal testing and strongly recommending it to our patients. So once we initiate testing, once we make this diagnosis, the name of the game is really prompt initiation of antiretroviral therapy. And I'm not going to go into the details of which medications we use and what the current recommendations are, but really suffice it to say that combination antiretroviral therapy has a bunch of goals, many of which overlap with any HIV positive person. Right? Our goal is to suppress HIV below our ability to detect the virus for as long as possible. And by doing that, we're prolonging this woman's life and we're improving the quality of her life. We're also able to restore immune function if it's already suppressed, or preserve it if it isn't. But for pregnant women, we have this additional goal. By bringing her viral load down, we have the ability to further reduce the risk of perinatal transmission. So prompt initiation of antiretrovirals. All right, intrapartum care. Remember, this is where the bulk of transmission occur. So I want to emphasize again, testing. If we don't know the serostatus of a patient, we can't implement these interventions. So sometimes patients will come in and haven't been tested. And testing in labor and delivery is our last opportunity before childbirth to identify a woman infected with HIV. All women with an unknown status at labor should have rapid HIV testing. So this means a woman that was getting regular prenatal care down the road, but is shopping on Michigan Avenue and comes in labor, yeah, she needs a rapid test. Or a woman who hasn't had any prenatal care, but comes in to the emergency department because of bleeding. She needs a rapid test, right? We need to know. We can't let anyone leave this hospital or anyone deliver here without knowing their HIV status. So why is this so important? And you remember in that earlier slide, we talked about those declination points, when we made these huge advances in maternal to child transmission prevention. And that second point really came from the results of this trial. So I want to spend a few minutes on it. So this is the PACTG 076 trial. And what this was is a randomized trial of about 500 high-risk women, so women with HIV. And they were randomized to what was the standard of care at the time, which was effectively nothing, avoidance of breastfeeding, or zidovudine. Now that zidovudine was given in 3 parts. 1, it was given to the mom starting at 34 weeks as a pill until the time of delivery. Intrapartum, she was given continued zidovudine through an IV. And then after delivery, the baby was given zidovudine syrup for 6 weeks after delivery. And the trial was actually stopped early. And it was stopped early because they saw this really profound difference. So women in the placebo group had a rate of perinatal transmission of about 23%. It's similar to what we saw before any interventions. But those in the zidovudine group had a perinatal transmission rate of 8%, so a 2/3 reduction. This really is a landmark trial, and it's the gold standard against which all other perinatal HIV prevention strategies has been judged. So you might say, okay, well, that's great, but what if we don't diagnose until labor? What if someone comes in and we rapidly diagnose her because she hasn't had prenatal care? Is there any advantage to giving that zidovudine during labor and postpartum, or is it really all in that antenatal antiretroviral initiation? So this comes from a retrospective cohort, so a series of hospitals in New York that collected their data and found that for women that got no intervention, rates of transmission were about 27%, so similar to what we've seen before. Women who got the complete PACTG 076 regimen, so they were started on maternal therapy, they got IV zidovudine in labor, their baby got zidovudine syrup, rates of transmission were 6%, right? So again, we saw that similar dramatic reduction. Women who didn't get the zidovudine until late intrapartum and their babies got the syrup still had a dramatic reduction in perinatal transmission. So their rate of transmission was 10%. So even by just identifying someone in labor and delivery, we have the ability to reduce the risk of perinatal transmission by more than half. So this is really empowering. So there's other avenues that are effective in reducing transmission. So these are data on cesarean section, and they come from a randomized clinical trial on the European mode of delivery, or by the European Mode of Delivery collaboration. And what you can see here, these were women with high levels of viral load, so viral load over 1,000. And these women were randomized to either a vaginal delivery or a cesarean delivery. And the idea is that Right, that intrapartum period, there's so much exposure during labor between the maternal blood and the fetal blood, as well as the fetus to maternal genital secretions, that maybe if we did a cesarean, we could bypass that risk. And so with this trial, what they found is that about 10% of women randomized to that vaginal delivery arm transmitted the virus to their baby, compared to 2 to 3% of those that had a cesarean. And so what this tells us is that women who have high levels of viremia, over 1,000, or women that we don't know their viral load because we've just diagnosed them, and so they're not on antiretrovirals, and we presume their viral load is over 1,000, there's a huge benefit to a cesarean before labor. And so ACOG, which is our governing body that kind of standardizes best practice in obstetrics, says that for a woman who's newly diagnosed or who has a viral load over 1,000, we should schedule that cesarean at 38 weeks. And the idea behind that is then we can perform the cesarean before labor starts or before membranes rupture. Because once one of those two things have started, the benefits of a cesarean are dramatically reduced. And so again, this offers another opportunity, if we can diagnose before labor, for us to intervene. Okay, so postpartum care, a couple things. So first, we really want to reduce exposure of the newborn baby to maternal blood and bodily fluids, and we do that by an early bath. Simple enough, right? So particularly important before the vitamin K shot that all newborns get is that these infants are bathed. The second thing, right, we know from the PACTG trial we've just talked about, is early initiation of neonatal antiretrovirals. This includes babies that are going to the NICU, babies that have low birth weight, low APGAR scores. Really important to get this medication started. The standard of care is to start this within 12 hours after delivery. And so that what that means on a systems level is that all hospitals need to have this readily accessible, because 12 hours can happen real quickly. So zidovudine monotherapy for babies was standard of care for over a decade, 15 years. But then we started thinking, post-exposure prophylaxis, which is effectively what that zidovudine is for a baby. For adults, we don't give monotherapy. We give multiple medications. And we really never give monotherapy any longer. And so does it make sense to continue to give just zidovudine, or should we be giving 2 medications or maybe even 3 medications to these newborn babies that are at high risk of contracting HIV? So that PACTG group did another trial, a randomized trial of very high-risk women. So women who had not had any opportunity to take antiretroviral medications until they were diagnosed at labor and delivery. And they randomized these women within 48 hours after delivery to one of 3 groups. So the first was zidovudine monotherapy, right, which was standard of care at the time. Double therapy with zidovudine and nevirapine, or triple therapy with zidovudine, lamivudine, and nelfinavir. I want you to kind of ignore the blue bars. The blue bars are in utero infection, and we really wouldn't anticipate that post-exposure prophylaxis for the neonate would have a significant impact on in utero infection. But let's focus on these green bars. What we can see from this trial is that the addition of 2 or 3 medications as opposed to just 1 reduced the risk of perinatal transmission, again, in half. So from 5% to about 2.5%. So we've extrapolated from this a little bit, and this is our current protocol. I don't expect you to read this, but I wanted to point out that we apply this. Remember, this trial was just for women with that had never been on antiretrovirals. We've extrapolated that to apply this triple therapy to women, all women that are at high risk of perinatal transmission. So women that deliver preterm, women that have virus that's present, that's detectable within a month before delivery, women that's seroconverted in pregnancy, because we know that's an independent risk factor. And so we apply that same strategy, this high-risk protocol now, to all of our high-risk women. All right, the last aspect of postpartum care is counseling about breastfeeding. So like I said before, the HIV virus is unequivocally found in breast milk. And we anticipate that an additional 15 to 29% of infants would be infected if breastfeeding is allowed. Now, internationally, there's not access to safe water or safe formula. And so when we compare infants that are breastfed compared to formula-fed infants are much more likely to not survive. And so in the developing world, it's recommended for women to exclusively breastfeed. But it's different in the United States, right? We have access to safe water, we have great formulas, and yeah, there are benefits to breastfeeding, but they don't really surpass the benefits of prevention of maternal to child transmission. And so what's recommended in the United States is that women with HIV should not breastfeed, should exclusively formula feed. And thought about maybe in a different way, anyone considering breastfeeding needs to know their HIV status. Now this sounds very simple, but it's actually a little bit more complex. So for some women, not breastfeeding in their culture is akin to disclosing to their entire community that they have the HIV virus. And that can result in a ton of social stigma. They can be shunned by their families. Their community doesn't support them any longer. And so you can imagine this gets very nuanced. The anxiety surrounding not breastfeeding is real. And so it's our job not just to tell patients not to breastfeed, but to communicate with patients about what were your desires with feeding, what barriers do you perceive to formula feeding, and help brainstorm with that patient how we can get around those barriers, how we can achieve formula feeding and reduce the risk of transmission. So I'd be remiss, particularly with my ID colleagues here, to not talk about follow-up maternal care. So right, if we've done all this work in diagnosing, initiating therapy, all this work to prevent perinatal transmission, our work isn't done just there, right? We need to be sure that we're linking these women to long-term specialty HIV care, and be considerate about, or be thoughtful about changing antiretrovirals after delivery if there's a need for this. We also need to be thoughtful about contraception and family planning. So certain contraceptives are more or less effective with some of the antiretrovirals. So there's a nuance in the contraceptive counseling to be able to optimally plan the next pregnancy. Monitoring adherence in the postpartum period, particularly to the neonatal antiretrovirals, is critical. And then monitoring for postpartum depression. So we know that postpartum period is a high-risk period for depression in all women. But now imagine someone's just been diagnosed with HIV. Right? You can imagine that additional stress of starting these new medications, the worry about their baby and their baby status. Are they going to disclose to their partner? Does their family know? All of this just compounds that risk. And so we often will see women that have a new diagnosis at 2 weeks postpartum to check in and make sure we're not leaving them vulnerable to depression for a whole 6 weeks. HIV testing of older children. So I think we need to be thoughtful. We've done such a good job of intervening for this pregnancy, but let's say she has a 2-year-old at home. And maybe she was tested in her first trimester, but this pregnancy was the first test since then. We need to probably test that kid, right? Maybe she's seroconverted during that pregnancy. And so we need to be thoughtful about who else may have been exposed and recommend early testing. Same thing for sexual partners or needle-sharing partners. All right, so I'm gonna kind of diverge off our traditional maternal to child transmission pathway and talk a little bit about primary prevention. So what I mean by this is if we can prevent a mom from contracting HIV, well then this makes our job a whole heck of a lot easier, right? We don't have to worry about any of these aspects of her care. And so when we break down how does HIV become horizontally transmitted, we used to think, okay, well, cases of sexually acquired HIV represent an HIV negative person that's having often unprotected sex with an HIV positive person. And that HIV positive person often has high viral load, meaning they're not yet tested for HIV, they're not linked to care, they're not engaged in care, they're not on antiretrovirals. But this construct puts all the power in reducing horizontal transmission in the hands of the positive partner. This leaves a negative partner without any ability to intervene, without any ability to protect herself. And so I would say in the past couple years, we can add something to this. Every new case of sexually HIV acquisition also represents an at-risk HIV negative person who has either not been prescribed or is not adherent to pre-exposure prophylaxis, or PrEP. So what is PrEP? So PrEP is a program. It's a program that combines once daily Truvada, which is an antiretroviral, a combination antiretroviral medication for the negative partner. And it's taken every single day to prevent horizontal transmission. But it's not just taking a pill. It's a program, meaning that negative person comes every 3 months and has comprehensive sexually transmitted infection screening, and any positive sexually transmitted infections are promptly treated. And so this PrEP program has been shown to be incredibly efficacious. So here's some key prevention trials I wanted to highlight. So first, in the green at the bottom, is the HPTN-052 trial. So this was a trial where there was where people were randomized to early initiation of antiretrovirals in the positive partner in serodiscordant couples, compared to initiation when it was otherwise medically indicated potentially later. And what they found is that early initiation and viral suppression in the positive partner reduced the risk of HIV acquisition by 96%. We never see numbers like this in public health. So really profound reduction. And I think that's really important to highlight. But again, that relies on the positive partner adhering to his or her medications. So in the red are 2 trials, and I've highlighted these 2 trials because one, they studied a heterosexual population, and 2, because these were trials where when they took blood levels of the drug, the patients in the trial were actually taking the medication. So the TDF2 trial and the Partners PrEP trial both showed about a 60 to 70% risk reduction in HIV acquisition with taking once daily Truvada in the HIV negative partner. So what's I think really exciting is that this has gained a lot of traction. So it was endorsed by the CDC and protocols developed in 2012. And in July of this year, President Obama released the National HIV/AIDS Strategy for the United States. And this is a component of the strategy: full access to PrEP services for those in whom it is appropriate and desired, with support for medication adherence for those using PrEP. So there's a lot of impetus behind the use of PrEP, but again, we can't use PrEP, we can't primarily prevent HIV infection unless we've diagnosed our patients and allowed our patients to disclose their results to their partner. A recent report from the CDC estimates that there's approximately 1.2 million Americans that have an indication to take PrEP. But there remain a ton of barriers to its successful implementation. And so I think one of the biggest barriers that we can intervene on is this lack of testing and identification of partners that are at risk. So I wanted, again, we talked a little bit about these data earlier on. This was from our PAC clinic, our low-income clinic here. And these are a couple other pieces of data I wanted to share. So in this study, again, we asked women, what do you know about your testing? What do you know about your partner's testing? Do you have a positive partner? And of the 142 women that we surveyed, I found these numbers really alarming. Only 44% were aware that they had an HIV test during their pregnancy. Now, I can assure you 100% had an HIV test. And so somewhere along the line, we're falling down in our pre-test counseling. Of these women, only half were aware of their HIV results. So we're also kind of falling down in our post-test counseling. And that's important in terms of just proper patient counseling, but I think our HIV counseling is also an opportunity to talk about risk factors and to talk about partner testing and to talk about safer sex. And so what this tells me is that there's a lot of room for improvement in our counseling. Maybe even more alarming is that during this time period, again, 142 women, no woman had disclosed to any of the MD providers that they had a positive partner. And yet in this anonymous survey, one woman wrote, I do have an HIV positive partner, but maybe she was too scared or didn't know that she should tell her provider. And so this tells me there's really an unmet need for PrEP counseling or for primary prevention of maternal to child transmission counseling in our antenatal clinics. Okay, so in the last couple minutes, we're going to talk briefly on some of the ethical and legal issues that come up in this patient population. And here's a list of just a smattering of some of the factors that occur: stigma, disclosure, intimate partner violence, mental health issues, anxiety about infection of the infant, and we'll go through some of these in more detail. I think the first aspect that's important to recognize is that in pregnancy, a woman is often the first person in a couple that's been tested for HIV. And so if she's found to be positive, she's often the one that's blamed by her family, by her partner, for bringing HIV into the family, when in fact she may not be the first person that was infected. There's, of course, profound implications in maternal-to-child transmission and that extra stress of, is my baby positive? Am I doing what I can do? And then we talked before a little bit about the potential for loss of support of her family or her community at a time when that support is so critical for her well-being. So the stigma and the discrimination that's associated with HIV, even still in 2015, can limit access to effective prevention, treatment, and the supportive services that exist. Disclosure to partner I want to talk about for a minute. So disclosure to one's sexual partner has a lot of benefits. So these are data from our OB HIV clinic here at Northwestern. And what we did is we looked back at patients we've cared for over the years, and we were able to determine, did they disclose to their sexual partner or did they not by the time of delivery? And then we looked at adherence to some of these maternal-to-child transmission parameters. So are they coming to care? Are they taking their pills? And what you can see from this are women who disclosed were much more likely to attend their prenatal visits. They were much less likely to miss their antiretroviral doses. It took them a shorter amount of time to achieve viral suppression. They were more likely to be suppressed by the time of delivery. And interestingly, people who disclosed were much less likely to deliver preterm. The other piece of data that came from this study is that there was improved adherence to the postpartum visit. So women who disclosed to their partner were much more likely to come and see us at 6 weeks after delivery. And that's our time to initiate contraception. It's also our time to make sure that they're linked to long-term HIV care. And so you can see huge benefits to her, the mom, and for elimination of maternal-to-child transmission adherence in women who disclose. There's also, of course, huge benefits in terms of reduction of horizontal transmission. Right? We know there's risk reduction with condoms. We just talked about PrEP. And if she's disclosed, then her partner could potentially initiate PrEP. So there's some benefits to her health, her baby's health, her partner's health. So should we mandate disclosure? Should we tell all women, you need to tell your partner right now? Well, the sad truth is that in the United States, 4 to 8% of all pregnant women experience intimate partner violence. And that number is so much higher in the setting of HIV. In fact, reading through the literature, rates are reported as high as 25 to 50% of HIV positive pregnant women have experienced intimate partner violence at some point. And you are probably familiar, a handful of years ago, a woman in Texas was murdered after disclosing to her partner that she was HIV positive during a pregnancy. And so what this tells us is this isn't so simple, right? Yeah, it's important to disclose, but it's important to disclose when a woman feels that it's safe to do so, and when a woman feels secure doing so. So there's a lot of resources that we have in our clinic to facilitate disclosure. There's a lot of resources the state has to facilitate anonymous risk-based notification. But again, this isn't just something that we have to rush a woman into. This is something we can help guide her through. So the last bit about disclosure is disclosure to providers. And these are data from our Illinois Perinatal HIV Hotline. And these are really alarming to me. So what we looked at is women who came into a hospital across the state of Illinois and were diagnosed by a rapid HIV test as HIV positive. We took these women and were able to determine which of these women actually knew that they were HIV positive before they had that test done. So for example, some women that maybe didn't get prenatal care before, but had been tested before, years ago, and there were records in the system. She was positive. She knew she was positive. Or women that had delivered at a hospital where they didn't get their prenatal care. So they were tested in the pregnancy, but there just weren't records at the time of delivery. And we divided these women who knew their HIV status into women who disclosed to their providers before that rapid test, came in and said, gosh, I'm HIV positive, and the providers, went ahead and confirmed, compared to women who did not disclose their status. Didn't say a thing, just waited for that test to come back positive. And this is the trend over time. So when the mandatory rapid HIV testing was rolled out in Illinois, 80% of women who knew their HIV status did not disclose to providers when they came in for obstetric care. Now, the good news for a while was we were getting better. Right? These rates declined to about 40%. Now, that's not good, but it's better than 80%. But what really strikes me is over the past 5 years, we've seen this increase in non-disclosure, that women increasingly are coming to our hospitals HIV positive and knowingly HIV positive, but for some reason perceive stigma, our inability to ask in a sensitive way, they're not telling us. And in this study, what this translated to were delays in initiation of preventative care. So it took longer to hang the IV zidovudine for the mom. It took longer to get that zidovudine syrup for her baby. And while it didn't overtly impact rates of perinatal transmission, thankfully, you could see that these trends in care could lead to this if we don't intervene. And so this tells me we have to take our medical history in a non-judgmental way. We have to make sure we're asking these questions in a private room without her partner nearby, without family members nearby. We have to be incredibly sensitive about what we're asking and how we're asking. Otherwise, we're not going to get the information that we really need to optimize care. Okay, so just a quick summary. HIV testing in pregnancy, hopefully you're convinced, it's truly the gateway to all elimination of maternal to child transmission services. No one should leave this hospital without knowing their status, and really everyone should know their status. In terms of elimination of maternal to child transmission, primary prevention, I think, is a real opportunity. So prep for negative partners. If we can prevent moms from getting infected, we can prevent perinatal transmission. For moms that are infected, early initiation of antiretrovirals, intrapartum zidovudine, early baby bath, and neonatal ARVs are really critical. And then again, I can't emphasize this enough, supportive care provision is critical. Getting to know these patients, getting to know their concerns, and making sure that we're communicating on the same plane. And with that, I'll take questions. Thank you guys so much for your attention.